Yeah, ladies and gentlemen, that was very basic. I'm still anyhow. I'd like to make it very simple. So we have to talk about imaging and interventional management of stroke. This is big. This is a big topic, and I have to cover it within 30 minutes. If we look at patients with stroke, this means majorly devastating disease, probably killing more people in the world than myocardial infarction. But for many years, it lived a life in conservative medicine, and nobody was really taking care of these patients. It's a disease, by the way, that is focusing on old people older than 20 years old. So there are a couple of simple rules if you find a patient, especially outside of the hospital. The FAST rule, which means look at the face, look at the arms, try to speak with the patient, and if you have any hint that this can be a stroke, of course, and this is not for you as doctors or students, this is for all people in the world, time is running, and time is the major concern in treatment of stroke. There are two basic scales you have to know if you deal with stroke. One is, which is very important, is the NIHSS scale. This scale tells you whether this is a severe stroke or a non-severe stroke. It goes from 0 to 42. It is not so easy to calculate. If you can look it up in the internet. It's mainly for neurologists, those neurologists who pick up the patient at the emergency unit or at the entrance. And there are some basic sayings. So if you have an NIHSS scale below 6, the prognosis for the patient is probably pretty good. But if the NIHSS is above 16, likelihood of death is high. And by each point up, you will have a decrease in excellent outcome. Excellent outcome, I will tell you later, by 17%. So this gives you some idea about the outcome of the patient once the patient shows up at the emergency room. And the other scale which is important in looking into stroke is the modified Rankin scale. The modified Rankin scale is mainly a scale that tells you about rehabilitation of the patients. And many of the trials that we are talking about later base on the outcome on the Rankin scale. So if you have a Rankin scale from 0 to 2, this means the patient is more or less capable to live his own life on his without major help. So 0 to 2 is regarded as an excellent outcome or a good outcome after stroke, while 3 and 4 patients are quite disabled, 5 severely disabled, and 6 is death. This Rankin scale is sometimes used also as a scale when the patient comes into the hospital in the acute phase. This is not completely correct because this scale is used only for the phase of before rehabilitation, at the end of rehabilitation. And if you look in trials about stroke, you will find that patients have an improvement in their abilities from the 30-day Rankin scale to the post-rehab Rankin scale. And rehab can improve the patient by a large amount. So that's important to keep in mind. So the diagnosis of stroke is simple. It's not as difficult as with tumors because I'm a general radiologist, and general radiologists are a little more simple mind than neuroradiologists, but what is problem is you have to be very quick, and you can use sophisticated tools to do the diagnosis of stroke, but you don't have to lose time. That is the main point. So the primary imaging in stroke is CT, native CT and CT angiography. Native CT has some basic tasks here. First of all, you should exclude bleeding. So if the patient comes in and you make the diagnosis, clinical diagnosis of probable stroke, you have to exclude bleeding because bleeding, of course, is a contraindication to anything else. And it is called stroke in the basic language, but it is not, of course, an ischemic stroke. It's a stroke caused by bleeding that has to be excluded. Second, you have to have some idea of localization. You have to have some idea of the extent, meaningly by negative signs. So if you don't have signs, that's good for the patient. If you have the signs of strokes in native CT, that's bad for the patient, because then treatment is no longer possible. And of course, it tells you a little about duration. And if everything shows you there's no bleeding, there are no late signs of stroke and infarction, then you perform CT angiography. And CT angiography is mainly important by patients with a severe stroke to indicate and to map the location of vascular occlusion in the brain. So we decide between early CT signs, which are good, and late CT signs. Early CT signs is a blurred border between the gray matter and the white matter. Or if you can't differentiate the basal ganglia very clearly anymore, if you have a so-called inch or a ribbon sign or a wedge-shaped hypodensity, and what is very clear and very easy to learn sign is the so-called hyperdense vessel sign. Just to show you this example, maybe it's not so easy to see on the screen. This is a patient with a severe stroke. What we see is a more or less normal CT of the brain. There's a little blurred differentiation in the basal ganglia here compared to the other side, but this is very discrete. And if you look at another slide here, the same patient, another location, what you see here, this is the so-called hyperdense media sign, which is, there is a hyperdense area here compared to the other side. There is no hyperdense area sign. This is indicator of thrombus. Thrombus material, once it's there, clot, it shows up to be hyperdense in the native CT. So what you do in a case like that, you have early signs of stroke, you have the clinical signs of stroke, you have no bleeding, and you have a hyperdense media sign. What you do is a CT angiography. And if you do CT angiography, it clearly shows you here, this is the normal medium, this is perfused arteries, and the other side, there is a missing perfusion of the medial artery, the middle cerebral artery, and this is the location of the clot, which showed up to be hyperdense on the native CT, and this is a central occlusion. This is another patient, another location. What you see here, this is the cerebellum, and there is a major difference in density of the cerebellum from this side and this side. And if you look at the MR, which was done 2 days later, in fact, you see this is a completely infarcted cerebellum on this side, and it's also swelling, compressing the other side. So this is a late sign, and this is a demarcated infarction, and this would be a contraindication, of course, for thrombolysis. There are, of course, different imaging modalities like ultrasound, duplex sonography, MRI. They all have their role in stroke treatment, but not in the acute phase or in special situations. This is a patient with a carotid dissection, and you nicely see the carotid, the true lumen in the carotid dissection, indicating that this is the cause of the stroke in this very young patient. So, is recanalization relevant for patients who have stroke? Yes, it is. If you look at the data from literature, recanalization is an important predictive factor. If you don't have recanalization, the outcome is very poor. If you have a recanalization within 6 hours, there's 6 times higher likelihood that the patient will have a good outcome compared with no recanalization. And even if the patient has a recanalization within 24 hours, the outcome is still 4 times better than in patients with no recanalization. So recanalization is important. And how to achieve recanalization? The standard treatment of care in patients with stroke, severe stroke, is intravenous thrombolysis. This is the basic treatment. But it is only possible up to 4.5 hours, or up to 6 hours in patients with severe stroke who do not show any signs of demarcation within this time limit of 6 hours. The problem is that approximately 2/3 of our patients do not receive thrombolysis or treatment from different reasons. But the main reason is that they show a late arrival at the hospital, and then they have late signs of stroke, demarcated infarct, and that exclude them from IV thrombolysis. So it's not because the stroke is not severe enough to be treated. The problem is that we have difficulties to bring patients to the emergency unit in time to undergo intravenous thrombolysis. All over the world, there is a movement to improve this situation, mainly by telemedicine and networking, by checking patients' neurology, by telemedicine, and to transport those patients to stroke centers in case they need intra-arterial thrombolysis or IV thrombolysis in IV units or in intensive care units. That is maybe, we don't know whether this will improve the prognosis of our patients, but it is one way to try that. The next question is, of course, is RTPA, which is the standard drug for treatment, is it safe? And if you look at the literature, it is safe. It does not increase the amount of intracerebral bleeding or significant bleeding. The mortality is not increased, and the Rankin score, especially by IV thrombolysis, is about 50% with a good outcome, 0 to 2 Rankin score. So IV thrombolysis is safe and standard of treatment. And why should we do that? If we look on effective lysis over time, you have to keep in mind that per minute of a brain infarction, 1.9 million of neurons will destroyed, 14 billion of synapses will be destroyed, and around 12 kilometers of nerve fibers will disappear if you don't treat the patients in time per minute. So you should be very quick in treatment. On the other side, if we look at all the thrombolysis trials, within 180 minutes of treatment, you need to treat only 9 patients to improve 1. That is a very good number. Even within 360 minutes, still 45 patients should be treated. That is not such a good number. 9 is a very good number. So, but now, even due to the ECHOS-3 trial, which is an updated trial, it is even improved. So 9 for 180, 21 within 360 minutes. And this is why we have the 6-hour rule, or we have the 4.5-hour rule in the treatment of stroke. So what is real life? If we look at our own hospital, we have around 1,000 patients with stroke being admitted to the hospital. Only 400 of these patients, 40% of them, will receive thrombolysis, which means 600 of them will not receive treatment. That's reality. And from these 400 patients, 50 patients will receive intra-arterial treatment, which is the treatment which is done by radiologists and neuroradiologists. So in Athens, only 5% of strokes or 12% of lysed patients will undergo interventional treatment instead of intravenous thrombolysis. When is interventional treatment of stroke indicated? This is pretty clear. In case of central obstruction, which means from the carotid bifurcation from the neck to the M1 segment, middle cerebral artery segment, which is the first part of the middle cerebral artery, all patients with occlusions of the basilar artery or a functional basilar artery occlusion, which means in patients who have only one vertebral artery and have an occlusion of this lonely vertebral artery. It is also indicated in patients who have a contraindication to intravenous lysis. There are a couple of patients who are having contraindications, patients who are under warfarin, under new heparin analoga, patients who had recent surgery, mainly brain surgery or face surgery, or patients who have a trauma, either just before the stroke or in conjunction with the stroke, which is not rare. Patient goes by bicycle falls down, nobody knows why did the patient fall down from his bicycle. He had a stroke and he fall down on his head and he has severe head trauma. These patients can have a contraindication to intravenous lysis and might be candidates for intraarterial thrombolysis or thrombectomy. Patients who have an early reobstruction after IV lysis, and which is a special group, are patients with a stroke in evolution, mainly due to a basilar stenosis, for example. So, if we look at patients who have recanalization or not, it is pretty clear. This is a trial from Kiel in Germany, and they looked on patients who had a hyperdense medius sign. And these patients underwent IV thrombolysis. It was a retrospective study, in fact. And those patients who had no recanalization by IV thrombolysis had a very bad outcome. Only 6 out of these patients had a Rankin scale of 0 to 2. Very bad outcome. While patients who had a recanalization had a very good outcome. We know that already. We have shown that by other works before. But what was interesting in this trial, they measured the length of the thrombus sitting in the middle cerebral artery. And they found that patients who had a length of the thrombus in the middle cerebral artery, which was longer than 8 millimeters in length, had no chance of recanalization, while patients where the thrombus was a little shorter, they had some better chances. But there is a zone starting from 4 to 8 millimeters where the outcome is questionable. So their conclusion is, as longer the thrombus is, as lower the chance of recanalization is, and these patients should undergo interventional treatment. And these are 3 candidates. All candidates have in common that they have extremely bad prognosis. This is a patient with a basilar artery occlusion. Has large arteries but no flow into the basilar artery. This is a candidate for dying soon. So in patients with basilar artery occlusion, treatment is obligatory. This is a patient with an M1 occlusion. The chances are a little better, but he will probably, without treatment, he will suffer from major disability. And this patient has a carotid T occlusion. A carotid T occlusion is not far from here, but it has a much worse outcome compared to middle cerebral artery occlusion. So all 3 patients are candidates for intraarterial treatment. And this is a special form of candidates for intraarterial treatment. This is an occlusion of the internal carotid artery right at the orifice of the carotid artery at the neck, at the carotid bifurcation, with severe stroke. These patients are also candidates for treatment. We will come back to that later. So if we look at the efficacy of the different options we have in stroke treatment to treat these patients, that's interesting. So 24% of the patients were recanalized spontaneously, and 52% of the patients were recanalized spontaneously after 24 hours of time. This is much too late, of course, and clinically it's not of any relevance. If we compare the intravenous recanalization, it is 43% in these patients, while intraarterial treatment is better, and combined IV and arterial treatment is a little more better, and mechanical recanalization is much more better because reaching recanalization rates of 80%, and I dare to say maybe 90% with new instruments we have. Coming back to the special situation of a tandem lesion. A tandem lesion is an acute proximal carotid occlusion combined with a distal central occlusion at the carotid T level or the middle cerebral artery. These patients have a very bad prognosis either, and they should undergo treatment. They have no good benefit by IV thrombolysis. And this is the patient you already know. This is the imaging. The imaging doesn't show any early signs of stroke. The CT angiography shows an occlusion of the middle cerebral artery, and the angiography, or the duplex, maybe in that case, shows an occlusion of the internal carotid artery at the level of the orifice. And this is the time. It came to the CT at 16:38. After 4 minutes, CT angiography was done, and the angiography took another 45 minutes. And then the first step was to recanalize the carotid artery by use of a stent. We see the MCA occlusion. The MCA occlusion was thrombolized in that case, was open at 7:45 to roughly 2 hours later. And this is what the outcome was in that severe patient of stroke. This is contrast media staining the infarcted area, and this is after 1 day the final infarction, which is very small compared to the basic findings of these patients. So there's little evidence on that, but if we look at the data, because these people are rare, or these patients are rare, there have been a total of a couple of papers published on that with small groups of patients. But what is important is that the combined recanalization rate is around 60% in this severe group of patients, and the good neurological outcome with a ranking score 0 to 2 was 45%. That's not gorgeous, but it is much better than the natural course. So how to treat a patient with an acute stroke interventionally? The basic treatment is to bring up a microcatheter to the level of occlusion. As you see here, this is the level of occlusion, small thrombus here in the middle cerebral artery. A microcatheter is placed at this side, and this is how we treated these patients until 5 years before. So then thrombolysis was started, and these were the outcome. The patient was lucky because thrombolysis was successful, opening up these arteries. The problem of the pure intra-arterial thrombolysis by RTPA is it takes some time. The efficacy is usually unpredictable because we don't know where the thrombus from. Does it come from the carotid artery? Does it come from the heart? Is it soft? Is it organized? So this is difficult for thrombolysis. And if an artery is large, the efficacy is diminished. So this is especially true for the carotid T. So thrombolysis in the carotid T is not as effective as in the middle cerebral artery. And also, during thrombolysis, the thrombus may be fragmented, but not thrombolized. And fragmentation means that parts of the thrombus will embolize further downward into the cerebral arteries on a level where you can't reach them. So people thought about how to improve the situation, and there is a huge group of different instruments having been developed over time, micro-retriever systems, hydrodynamic thrombectomy, aspiration systems, intracranial stents to place on the thrombus, and we ended up, and this is the last development, are stent retrievers. This is a micro-retriever, so-called a dinosaur compared to the stent retrievers. These are first versions of stent retrievers, and the same treatment is done as before. You place your microcatheter, you remove you place over the guide wire, then the microcatheter is in place, then the instrument is developed, and then it is pulled back into your delivery catheter, and by that the artery is cleaned. And stent retrievers do the same, but in a more relevant, or in a more safe way. These are stent retrievers. The stents were first developed to place across the neck of aneurysms to facilitate coiling of aneurysms, but then people found that you can use them also as cleaners for the cerebral arteries. And by that, the same treatment is true. This is a thrombus here. Then you bring up your guiding catheter over a guide wire. You place your stent retriever, and then you wait for a while. It's important to wait for at least 1 minute. You leave it in place. The thrombus can go through the struts into the stent retriever, and then you pull the stent retriever gently out of the artery, and by that you can recanalize the artery. So the question is, what system should we use when? First of all, it depends much on your personal experience, but also, of course, on the socioeconomic conditions in the medical system you live in. In our system, thrombolysis is now the only third-line option, but always combined with IV thrombolysis if possible. And probably we think that stent retrievers are most effective. So our actual algorithm is that we use stent retriever first. If they fail after 2 or 3 passes, we will go to thrombosuction. And if thrombosuction fails, then we would start an IA thrombolysis. To be honest, it happens very rarely that we go beyond step number 1 nowadays because they are very reliable systems. So if you read literature, probably you came across 3 papers which were published early last year. All 3 have been published in the New England Journal of Medicine. And if a paper is published in the New England Journal of Medicine, you think God has spoken to you. And now God has spoken 3 times to you, right? But unfortunately, it is not God. The problem is these 3 trials, which are highly cited in many papers, are outdated. They use mixtures of thrombolyses, different instruments, long time windows, and they are not reflecting the actual situation of treatment of stroke. So everybody who is involved in interventional stroke treatment is convinced that they do not reflect what we do for the moment. There are 2 other papers out, published in Lancet, probably not as high-ranking as New England Journal of Medicine, but close to God. And these 2 papers compare the old mechanical systems we used, like the Mercy retrievers, compare them to modern devices we use, the stent retrievers. And both trials could show that the efficacy and the recanalization rate was much better with modern stent retrievers compared to the old mechanical systems. And if we keep in mind that recanalization is the key factor of outcome in the patient with stroke, people who are involved believe, to be honest, believe that there will be a change, but there is no randomized truth for the time yet. So in conclusion, with retriever first option, we are quicker and we have more recanalization success. And until further notice, this approach should be the treatment of choice in accepted indications. And if we look, or if we perform randomized trials on this, they should fulfill very strict time criteria, patient selection, and protocols. And the problem with randomized trials is always that they try to bring in many, many patients, and then they blur the indications in inclusion criteria. That is a problem of evidence-based medicine. And to be honest, the question is, are randomized trials in these subgroup of patients who are candidates for intraarterial treatment, are they ethical? My personal conviction is no, they aren't. Thank you very much.